Welcome to the Brimful Podcast. I'm Pamela Tessman, an IBCLC, a mother of two, and former childbirth educator, doula, and ACE. I share evidence-based tips and stories on infant feeding and the perinatal period. This podcast is for educational purposes only and is not a substitute for medical advice, so please always see your healthcare provider if you have concerns. Be sure to follow me at brim.familycare on social media or visit my website at brimfamilycare.com. Let's get started. Welcome back to another episode of the Brimful Podcast. Today we're talking about something that many postpartum parents experience, but almost no one talks about: vaginal dryness, discomfort with sex, urinary symptoms, and pelvic floor changes during pregnancy. My guest is a pelvic health physiotherapist, Professor Sinead Dufour, and we're diving into the Genitourinary Syndrome of Lactation and how it affects postpartum recovery. So welcome, Sinead. Can you introduce yourself for our listeners?
Yeah, of course, Pamela, and thank you so much for inviting me to chat about this topic. So I'm Sinead Dufour. I'm sort of an academic clinician. So on the clinical side, yes, I'm a pelvic health physiotherapist. I've been a clinician for over 10 years, or 20 years rather. But academically, I do a lot of work at McMaster. So I teach, I do research. Very much in the research side and the clinical side. I'm based in Oakville, Ontario, not too far from Hamilton, where McMaster is based in Canada.
Great. Awesome. So are you able to see people online, or is it just in person?
Yeah, that's a great question. Actually, at this point in time, all my practice is virtual probably because I've been doing this for 2 decades and I'm quite specialized. People kind of hear about me and they don't live close to where I live. I do virtual clinical care.
Perfect. So let's dive right in. Many people have heard about the genitourinary syndrome of menopause, but I feel that less people know about the similar symptoms that can happen during lactation. So would you mind just explaining what GSL is for our listeners?
Yeah, absolutely. So as you just kind of preluded there, Pamela, it's newer kind of awareness raising on this side of things. There was a group lead author was Sarah Perlmutter. She's a physician in the US, publishing a big review in 2024 and really just highlighting the fact of, look, we have this sort of parallel state that is similar to what we see in perimenopause, primarily related to estrogen depletion, right? But we're seeing that same type of clinical presentation, not for everyone, but for certainly a subgroup of people in the postpartum period, particularly if they're breastfeeding, because again, we're in an estrogen depleted situation. So very much these things do parallel, right? So because of the lowered estrogen, we have that same effect on the vulvovaginal tissues. So we have the tissues that are thinner. We have a little bit sort of less compliance in that bladder muscle. So a little bit more sort of urgency, frequency. Because estrogen is dropped, pH shifts, the microbiome shifts slightly. So this makes the area almost like the immune system capacity a little bit less robust. So we see kind of increases sometimes in urinary tract infections, not as good ability for lubrication, more dryness. So essentially, it is that cluster of symptoms that people, I think, expect in the perimenopause state, but it's happening in that postpartum period, particularly for people who are breastfeeding, because of course the prolactin, that hormone that kind of stays high when you're breastfeeding, that keeps estrogen low. So that kind of really sort of promotes that ongoing sort of lower estrogen state.
Yeah, that makes a lot of sense. So how common is this? Like, what do you see in your practice?
Yeah, so what I would say is, probably to be fair, there are many people being missed, right? So I would say probably even my guess. So one, the research this is an area that's quite new. It's really important that this is now on the radar. So that's really, really good. And I know there's a number of groups that have, research that they want to do to see kind of how similar is this, presentation of this issue to perimenopause, menopause, because there could be differences, understandably. But this is something that I would say I have sort of witnessed in my practice since I was very much focused in perinatal care and pelvic health, which is about the last decade. But like a small part of my caseload, I would say this was on the radar. Like maybe like 10% of folks in the postpartum period, this was on my radar. But to be fair, it has been on my radar kind of the whole practice, primarily in the case of painful intercourse. So this is why I think it's so important that this is being discussed more, because there are many, many more symptoms beyond intercourse where this is implicated. And there's many moms who, for a whole variety of reasons, penetrative intercourse just isn't a priority and it's not important to them, maybe even for their whole first year. But this thing might be manifesting in all these other disruptive ways, right? So yeah, I would say it has showed up in my clinical practice in a very sort of small percentage, but I suspect the issue is actually bigger and people just haven't come forth to talk about it. And even as far as clinicians are concerned, because it hasn't really been on the radar with a label for us, we haven't really been as prompted to discuss it. In fact, Sarah Perelmutter, who I just mentioned, who really her group's work kind of has led the charge in this, their hope actually, the fact that they kind of coined this, genitourinary symptoms of lactation, was to actually have language to empower healthcare providers to be able to talk about it. And then on the flip side, empower sort of clients and mums to be able to talk about it. So hopefully, it has that intended effect and it isn't really like another pathologizing of sort of what happens. Sometimes I think we have an intention for something, but then, it doesn't have that intended effect. And I tend to not love labels. So yeah. I guess we'll see. But it's great that we're talking about it.
Absolutely. And I think it's great that that can potentially be part of the conversation at the 6-week mark when, women and AFAB people are like, well, things aren't quite feeling right for me. And perhaps they're being told, this is just normal because this hasn't been a part of the conversation before. So I love that that's being brought forward and into the light a little bit more. So what do you provide to people who are navigating this?
Yeah, so I mean, certainly, and this is where, there is research studies in place just to verify that, the care solutions that we know work really, really well, tried, tested, true for genitourinary symptom of menopause, just to make sure that we've kind of retested those same interventions with kind of postpartum lactating groups. So we don't have as much data. But from what we do know from these estrogen depleted states, there are a variety of strategies that can be really, really helpful. So I'll kind of almost sort of go in order of from my practice perspective as a pelvic health physio. What I would kind of say is sort of most conservative are the things that actually are within my scope of practice to kind of engage with the client in, to kind of the end that's sort of almost more now on the pharmacological side, okay, which is outside of my scope, okay? So pelvic floor muscle training in and of itself, we know that that's actually a really good strategy, right? So even some really well done research has been conducted right here in Canada, in Quebec, and just highlighting that really getting that consistent blood flow and pumping of that blood in that area can be really, really helpful. Right, so we know pelvic floor muscle training, and we know for pelvic floor muscle training to be effective, really it should be sort of individually tailored and guided. And so this is where even just having, a session even virtually with a pelvic health physiotherapist just to kind of guide you can be really, really helpful. So that's one option. Another option is vaginal moisturizers, but vaginal moisturizers that specifically have the active ingredient hyaluronic acid. So there are vaginal lubricants that sometimes people will be told, especially if their main symptom is dryness or painful intercourse, which often is one of the symptoms. Sometimes mamas are really dismissed and they're just told, use lube when you're doing anything penetrative. But this isn't really what we're talking about with that symptom. It's not just you're having difficulty with something penetrative. You can be sitting at rest and having a lot of dryness that's very, very uncomfortable. And so we actually need to treat and penetrate that tissue that's kind of thinned out and dried out. So using a moisturizer that has the active ingredient hyaluronic acid, not unlike how it would affect your face, right, and plump up your face and get rid of wrinkles, we see that type of a moisturizer plumps up the tissues of the vulvovaginal area. And so typically when people are using a compound like this, it's over the counter. They will use it every single day for 2 weeks and then kind of twice a week thereafter, right? To actually get a legitimate treatment effect, right? So that's another great strategy. That's not to say that in addition, people might not also want to use lubrication for certain tasks, but it's to really clarify we're talking about two different things. And then another sort of emerging area of treatments is photobiomodulation. So different types of red light therapy and laser. And so there's some emerging data highlighting that these types of therapies actually can kind of be quite helpful to kind of build up the robustness of the tissue in that area when systems are quite depleted and even when mitochondria is depleted, because we know there's lots of different systems at work here that sort of interface with the endocrine system, right? And as we're getting that thinner tissue, any types of tools that we have that are going to bolster up that tissue, understandably are going to be helpful. So that's another kind of more modality that's emerging. And then kind of more on the other end of the spectrum, if we say pelvic floor muscle training is kind of on one side, on the other side, we have vaginal estrogen. So vaginal estrogen, certainly from a Canadian context, needs to be a prescription. So in Ontario, which is where I'm based, it can either be prescribed by your family doctor, your nurse practitioner, your gynecologist or OB or any type of specialist, or a naturopathic doctor who has prescribing capability. So in Ontario, some naturopathic doctors have prescribing capability, and they are also able to prescribe this, right? So this needs to be prescribed. But the data is really, really solid. In fact, even in the most recent clinical practice guidelines from the Society of Obstetricians and Gynecologists of Canada, frontline strategies are hyaluronic acid, pelvic floor muscle training, lifestyle, all of those things. And then the next one is vaginal estrogen. And vaginal estrogen can come in different formats. It can come in a pill, it can come in a ring, it can come in a cream. And so it's also important to understand that not every different mode of it works as well for each different person. So if someone, for example, is having kind of really a lot of kind of thinning of tissues, kind of really at the entry of the vaginal area, they probably are going to do better with cream over that area. So the actual receptors, estrogen receptors in that area can really soak up all the estrogen. Whereas people who are kind of feeling more deeper, drier, they're having urinary urgency or kind of discomfort on deeper penetration, maybe the tablet that gets inserted right up in that area or the ring would be an appropriate mode of delivery. So it's also kind of important to think if you've tried one, but you're still having symptoms, don't necessarily think you need to give up on it. You really want to make sure you've had a chance to talk to someone to go through all the different little nuances, because it is such a kind of conservative care strategy that's really, really effective. So we want to make sure we have really tried it properly before we make the assumption that it hasn't worked.
Right. That makes a lot of sense. And I think it's also important for our listeners to know too that When we're talking about topical estrogen, it's much different than systemic estrogen, because if you are preferring to breastfeed, taking a systemic estrogen may affect your ability to lactate and produce a robust milk supply. So it's really important to know that distinction when you're navigating all of that.
And actually, that is one area where there has been some research done, Pamela. So I should probably highlight that. And it really is to affirm that, yes, like in the studies, it has been affirmed that when vaginal estrogen has been used, this has not, when they have tested it, landed itself into the breast milk. So you're quite right. There still can be some discomfort and some lack of trust sometimes with some moms with hormone therapy in general for a whole variety of reasons. And so I think it is important to be clear that we do have proof this isn't going into your breast milk. It really is quite a local treatment. That having been said, for individuals who are having sort of these issues, we also want them to understand vaginal estrogen is a great option. I would argue it's probably the most potent option and still a really nice conservative option, but it's not the only option. So if you are someone who's still, that just doesn't really land well for you, the hyaluronic acid moisturizers are excellent. You know, the pelvic floor muscle training can be really helpful. As I said, the photobiomodulation, and also understanding that, you know, there are other systems that work with our endocrine system, like, you know, our liver detoxification works with that system. Our thyroid works with that system. So a lot of time these moms are quite depleted in those other systems. And, you know, we're not thinking about that. We can bolster up those systems, and that actually supports their endocrine system. So there are lots of different ways we can support people depending on their preferences, but definitely we want to make sure that we can find a solution that they can still be breastfeeding, right? Because we want people to be staying with breastfeeding if that's their choice, because of all the benefits for mom and baby, right? So there's lots of ways we can kind of work around that.
For sure. It's going to be different for everybody, so definitely has to be a holistic approach. So are there any other pelvic health challenges that you typically see in postpartum?
Yeah, so, and I would say this is one of the reasons also too why this issue probably has maybe almost like slipped through the cracks a little bit. Because to be fair, in the postpartum period, you know, oftentimes, not always, but oftentimes, you know, mamas are recovering maybe from an injury to their pelvic floor or their perineum. And it can sometimes be thought, oh, well, you know, they're complaining of painful intercourse, or it's kind of dry, or it feels like it's like pulling or itchy in that area, but they have an injury that's healing, right? So we have many individuals who are recovering from sort of injuries and stitches, and they've required stitching. Also, urinary incontinence or increased urinary frequency. Yes, these are reflective of a low estrogen state, right? But these are also reflective of the tissues not being nervated quite as well as they were. We know that the pudendal nerve, which is the peripheral nerve that supplies the pelvic floor, I mean, even if you didn't sustain a tear when you birthed your baby, this nerve stretches so much that, you know, biomechanical designs point every single time that it's very, very likely that the axons in that nerve are going to kind of injure, right? And so we know there is a little bit of like a recovery period, even from that perspective. That's probably also one of the reasons why pelvic floor muscle training is so helpful across the board, because when you're contracting that pelvic floor, that stimulates nerve regrowth factor, and that kind of helps like with the healing kind of everything. So yeah, I mean, these injuries to the pelvic floor are common. Urinary incontinence is common. Sometimes even just not the muscular tissue, but kind of the inert connective tissue through the pelvic floor has maybe taken a bit of a hit through pregnancy if mom was really constipated through pregnancy and straining a lot. If mom was sick and like chronically coughing a lot, we can kind of have these other things go on. And I think sometimes, certainly as a pelvic health physiotherapist, some of these things end up more being our priority, and then they can kind of be meshed in with some of the things that really need a boost from maybe a little bit more estrogen. They maybe need a boost of hyaluronic acid. They maybe need us to be putting on that lens in our thinking rather than more like our rehab brain on. So yeah, there is a whole myriad of things. And even, if we think of mental health for moms, right? We know that kind of lower estrogen, that impacts with our serotonin system and all of these other systems. So we can kind of be navigating a lot of these other issues as well, which on the flip side, that can actually be a benefit of getting a little bit more estrogen sort of on board. So there is a whole slew of things that these moms kind of can be presenting with and often are presenting with. And I think that's actually one of the reasons why this lower estrogen state and this clinical profile that goes hand in hand with that sometimes has gotten missed. So I can say, like, from the perspective of a pelvic health physiotherapist, the fact that we have this new terminology, I actually think that will help pelvic health physios kind of be able to focus on this more in their practice. So, I think it will work, and hopefully the same is true for lactation consultants and others. But yeah, absolutely a whole myriad of things that postpartum moms are trying to navigate and needs some guidance, because these are common issues, but they're not normal. There's many ways we can support these things. And so we want to make sure, that people are getting the guidance and help that they deserve and that they need.
Yes, it can be so confusing navigating all of that.
Yeah.
I also find that there's a myth that if you have a C-section that your pelvic floor is fine, but we know that that's not necessarily the case too.
Yeah, absolutely. And even coming back to, so I think that's a really good point. So when we've had a cesarean birth, yes, the data shows that you're less likely to have really, really severe incontinence, because really, really severe incontinence tends to go hand in hand with vaginal births that have sort of operative births aspects in them, right? Episiotomy, vacuum, forceps. And so, yes, if you have a cesarean birth, you're avoiding that, but there's still a lot of studies that show, lower grade stress incontinence is an issue. We see that painful intercourse is a big problem with cesarean births because all the endopelvic fascia is held so tight. Also, depending on how you've had that cesarean birth, if it really was not your plan, you had a trial of labor, this all happened, you're feeling very overwhelmed, like the rug was pulled from under you. That is a very distressing state to now be in, and now you're caring for your child and you're sleep deprived. So there's this automatic protection response that goes into the pelvic floor. So there's lots of kind of things we have to think about with cesarean, but also if then you're exclusively breastfeeding, or in my case, I had a cesarean birth, but I had twins and I was exclusively breastfeeding my twins. You're in a very estrogen depleted state. So, you're also going to have all of these, genitourinary syndrome of lactation, and you've had a cesarean birth, right? So absolutely, we have to be kind of thinking about the pelvic tissues from a physiological perspective, from sort of a distress trauma perspective, from all of it.
Yeah, all of it. So what would you tell parents who are having some of these symptoms that you really shouldn't be ignoring?
Yeah, absolutely. So I would say that, we usually generically say standard tissue healing, provided that you're sort of within a context that allows for optimal healing. So I'll kind of come back to that in a minute. But standard soft tissue healing is about 4 to 6 weeks. And that's why sort of our healthcare systems are sort of set up. Like if you have midwifery care, you're seeing your midwife at 2 weeks, 4 weeks, 6 weeks. If you have an OBGYN, you're seeing your OB at 6 weeks, right? And the idea is that, yeah, probably most of the soft tissue healing is sorted out. So if everything kind of seems good, we can kind of feel confident you're good. And if something is flagged at that point, we're thinking, okay, we probably need to like engage in some other care, right? So really, I would be saying like definitely by that 6 week point, if you are having a lot of dryness, pain, urinary urgency, urinary frequency, symptoms that almost feels like you might be having a UTI, anything, even if it's minor, that is something you should come forward with, right? It really, really is, even if it's very, very, very minor symptoms. Because I mean, as soon as, you know, the topic is broached and it gives an opportunity to dialogue, it's quite possible that then it can kind of be clear that other things are sort of going on. You know, you might be then questioned about sort of like bowel habits or other issues that you hadn't put those things together yourself. And then your healthcare provider is kind of able to put things together. So really, I would say any type of symptom that's kind of on your mind that you think, no, this is still uncomfortable and we're sort of past that 4 week mark, or it's interfering with your life, or you're even worrying about it, even like the littlest bit, it's creating some type of inconvenience for you. These are things that need to be brought forward. Because when it comes to pelvic health, really, I mean, one of my biggest frustrations is that it's an area of physiotherapy that we probably have like the highest level of evidence, like the highest assurance of really straightforward things that work really, really well. Like even if you compare other aspects of practice. And the issue really is that this is not mobilized well. So not the majority of primary care practitioners don't mobilize this information well to their patients. I teach in the family medicine program at McMaster, and I teach the pelvic health module. And most medical schools don't even have this in their curriculum, right? So that's the frustration, is that we have such basic care strategies that work so incredibly well, but they don't get to where they need to. And some of it too is because, you know, the individual themselves is normalizing it. Don't normalize it. If you have something that's going on past 4 weeks, bring it up, right?
It's valid.
Totally. Mm-hmm. And if you feel like you hit a dead end sort of in your regular sort of medical system, bring it up to your lactation consultant, bring it up to your pelvic physio. Like you can kind of go sort of outside that usual path and engage with people and ask.
Yes. So in that note, just so that listeners know, you don't need to see, or you don't need a referral to see a pelvic floor physiotherapist.
No, you don't. We're considered first access primary care practitioners. And I would say up to about even maybe like 7-8 years ago, some private insurance plans would require a doctor's referral to reimburse you from your insurance. But that has not been the case for, you know, over 5-6 years in Canada. So yeah, you can just come right to see a pelvic health PT, and then it, provided you have benefits, or you can just afford to pay out of pocket, and you can just go right and see someone.
Great. So can you walk us through what an appointment with you might look like?
Yeah. So I'll first maybe walk through what an appointment would have looked like with me a couple of years ago when I was doing some in-person care. And then I'll talk about what it looks like with me now doing online. So if you were seeing me in kind of my more traditional way, I would see people, which is, I would say, probably 90% of the pelvic health PTs across the country. This is probably how they do care. And then there's about 10% of us that do hybrid care or just virtual. But really that first appointment, quite a bit of that time actually is really talking to you and listening to you, like wanting to know your symptoms, wanting to know what your pregnancy was like, what was the birth like, what has the postpartum kind of been like for you, because we can get a lot of clues in terms of like the status of your physiology and other things that gives us kind of some hints So we can really kind of individualize your care. So a lot of it is really trying to gather as much data as we can to kind of understand you as a person, right? And then once we kind of have that information and we kind of want to get an idea of, okay, so what do things kind of look like in the pelvic region of your body? So we will do kind of more of a standard external sort of movement assessment. Make sure your hips are moving well, check your abdominal wall, because like this whole system works really well together. But then usually that sort of last final part of our meeting on that first day, provided that the client is interested in this and is consenting, typically if people have sought out the expertise of the pelvic health physio, like they actually want the really, really detailed exam, we will do sort of an internal vaginal exam so we can actually assess the tissues. This does not take very long. We will first kind of look at kind of the external genitalia, which is called the vulva, because when it comes to the genitourinary syndrome, one of the key flags of that is actually sort of atrophy and thinning of these tissues. So these tissues will look kind of less plump. They often have a paler color. So we're kind of looking for that. We also might see, you know, kind of like evidence of lacerations or sort of areas where it looks like healing has not happened very well. And this is another important place for vaginal estrogen. It has been proven to really help with tissue healing, right? So even if someone didn't really have those classic symptoms, but we check them, we think, oh, wow, like this tissue, you're already at like 12 or 13 weeks postpartum. You're almost out of that fourth trimester. And we really would expect this tissue to be kind of healed better. That can kind of give us some clues of, okay, what are some things we can do to get that tissue healed better? And this is where the photobiomodulation we know is good for tissue healing. This is where estrogen is good for tissue healing. This is where pelvic floor muscle training is good for tissue healing. So we're kind of flagging all of those things. And then, you know, our hands are obviously gloved. We do a very gentle, what we call digital exam. So using our fingers inside the vaginal walls, because that's of course where the pelvic floor muscles are. And we can gauge if the pelvic floor muscles are contracting and relaxing well, if the pelvic floor muscles seem to really be sensitive to the touch, if the pelvic floor muscles seem to have a lot of sort of protection and tension through them, if it kind of seems like the anterior or posterior vaginal walls are kind of like collapsing a little bit into the vaginal space, that might clue us into, you know, maybe the organs sort of need a little bit better support at this time. So we're able to get a really comprehensive sense of all the tissues through a very sort of quick exam. So that's essentially kind of what your first session would look like if you were in person with someone. If you were kind of consulting with me now, it would essentially be that first bit, really talking to you, gathering all the data. And then I actually get people to kind of do a little bit of a movement screen through the camera. So I can kind of get a gauge of, okay, when I'm asking them to do this figure 4 position, does it look like they have a lot of tension around the outside of their pelvis? You know, the hip muscles are very much connected to the pelvic floor muscles. I have a number of kind of validated screening tools that I'll use so I can just be more confident in like the accuracy of the data I'm completing. One of them that's called the Central Sensitization Inventory. We know that if people score high on that it kind of tells us that their whole system is in a little bit of this kind of sensitized state. And that sensitized state correlates with sort of that clinical finding of sort of a sensitive, tender pelvic floor and palpation. You know, we've actually done research to validate this. I've actually done research with the team. I led that research a number of years ago.
Amazing.
So we can kind of garner some of that data, even through doing an exam that way. And then if at any time through the course of kind of working with someone, they decide or I even suggest that it sounds like it might be good to actually have some eyes on them. You know, those of us who do virtual care, we're usually pretty well connected with different areas. We can kind of have a list of really good people that we can refer to kind of bring maybe someone in person, like into the circle of care, with us. But there's a lot we can do to help guide people in evidence-based, effective sort of menu of options, and then the client can kind of choose and figure out what's best for them without necessarily having to see them in person, provided I'd say that you're really, really experienced and you've kind of done this for a while and you understand practice patterns and things like that.
Right. Yeah, that makes sense. And I love that this is essentially helping people get to know their bodies a little bit more too.
Absolutely. And demystify it a bit. You know, my agenda when I kind of first came out as a physio at the end of like an assessment was to get through my chat with someone. And then I had this agenda of all these kind of assessment things I kind of wanted to do. And now I approach care very differently. Like my agenda is to have the person I'm speaking with understand why they're having the symptoms they're having, and like to be able to make sense of really what their body's been trying to tell them, right? Because that's what symptoms are. They're communication tools, right? And I think we often misinterpret them. And so really at the end, I want my client to kind of, okay, I get it. And I get it why this is happening. And this isn't happening because your body's doing something wrong. This is happening because this is how the body is designed to adapt when it doesn't have estrogen, when it hasn't been sleeping, so your body is doing what it's supposed to do. What it actually needs is support. It actually needs to sleep, and even that can be really helpful for people to understand your body hasn't gone rogue. It hasn't done something wrong. It's doing exactly what it's supposed to do. It's just you don't understand how it works. So once you understand how it works, and once you understand the gaps and how it's trying to adapt to fill the gaps, but we're actually going to support the gaps in a better, smarter way. That's always sort of the goal and the agenda. And again, like the ways people can support themselves and get guidance for support are very accessible. So it's just so important that more people know about it, right? So it's great, Pamela, when people like you have these podcasts to start talking about these things, because even just perimenopause, menopause is only kind of more recently sort of having its heyday where we're really talking about it. And so, you know, these similar symptoms and cluster of symptoms in a similar state in lactation and postpartum, it's the newer kid on the block, right? So we're just kind of really starting to talk about this, but it's really important because there's so many things we can do to help.
Yeah. And speaking of the postpartum stage and the perimenopausal stage, sometimes that's happening all at once.
100%. We're seeing that
families
more and more.
are having babies later. Yeah, you're seeing that a lot.
Yeah, we're seeing that more and more, that it's almost like this intersection of, you know, mama feels like, oh, she's finally just got out of postpartum, and almost feeling like she can never actually get back to feeling like what she remembers as normal, because actually she's going right into perimenopause, right? And that can be a really kind of, even identity-wise, like a tricky place. So if we also have a ton of these bothersome sort of physical symptoms that aren't being understood well and addressed well, when they can be addressed quite easily, it can be really, really difficult for moms. So I think all of us have the onus to kind of understand the full sort of spectrum of what can be happening.
Absolutely. Well, thank you for sharing all of that. Along with your teaching and your private practice, do you also mentor and work with other physiotherapists?
Yeah, so with my clinical practice, it's called The Womb, The World of My Baby. So, and I'm a founding partner of this practice. So we have 6 of them in the province of Ontario. So I have teams of pelvic health physiotherapists that work at all of them, which is great. I spent a lot of time mentoring my physiotherapy team. And and then I guess because I teach in the physiotherapy program at McMaster as well, I teach in the School of Medicine and the School of Rehabilitation Science. I do quite a bit of even like mentorship with like newer graduates and things like that. I teach an elective course at McMaster all about sort of perinatal care and pelvic health. So, yeah.
Lovely. Is that in person or can people do that online?
No, that's all in person. That is all in
Okay.
person at McMaster just for physiotherapy students. But I teach a number of postgraduate courses that anyone can take through a company called Embodia. There's a lot of us physios that teach through this company. It's called Embodia. All of the courses are on demand online, and I teach a number of courses through Embodia.
Very cool. So where can people find you then?
So people can probably find me easiest at my McMaster Experts page. So even if you were to just Google my name and McMaster Experts, my kind of page comes up. It shows all my publications, all my teaching. I do a lot of work with FIFA, with Margie Davenport. So we're busy doing tons of research and teaching with that, all in pregnancy, postpartum, and exercise. So kind of links to that. And then my Instagram, I'm pretty busy on my Instagram, posting a lot of like updates of research and kind of pelvic health, perinatal care. It's a professional page. It's not a personal page. And that's at dr.sinead.
Wonderful. Thank you so much for taking time out of your busy schedule to speak with me today.
Okay, thank you for having me, Pamela.
All of the links mentioned to connect with Professor Dufour can be found in the show notes. And if you liked what you heard today and appreciate the podcast, feel free to buy me a coffee. See you next time.